Good afternoon, everybody. We are live. I'm ready for the COVID update. We have 15.
Okay, 20 or so we're up to. We'll give it just another minute or two. Looks like our special guest today, David Hudak, has brought his own fans with him, so that's good. Jasmine, do we have a picture of a particular Lieutenant CME instructor that we might be able to share today?
I'll work on that.
Do you have an electronic copy, or should I just hold it up?
You can do that.
You know what I'm talking about?
Oh, yeah, you should just hold it up.
I would just like to know if anybody can tell me if this guy is in the audience.
You got to take your virtual background off. Or that works too.
Oh my God.
That guy. Is that guy in the audience? Is he here today? Somebody? I hope so. That's pretty amazing. That's pretty amazing. All right. So we don't have too many folks on here yet. It doesn't look like, so we usually start a few minutes late. So maybe we'll just give them a couple more minutes and then we will go. Or maybe just everybody's over COVID. I mean, that could be too.
I don't blame them.
Yeah, no kidding. Unfortunately, it ain't over. So I'll go ahead and just throw up today's numbers so we can all be happy about it. And here we go. If it's loading, I guess. I don't know. Still loading. So anyway, we're 66,000 cases in the state of Florida for today. Seems like maybe we're trying to refresh this. And while that's refreshing, as you can see, there's been what appears to be a slight little uptick here over the last couple of days in terms of number of cases. So this thing seems like it's being super slow, but maybe we'll get there. Here's Pinellas, 1679 altogether, 99 deaths. Age range is still broad, and you can see the rest of the demographics here. So this is what's going on in the state. I think probably what's maybe more revealing is this guy. You can see here's a summary of the testing that's going on. So we have increased our testing numbers, but in addition to seeing more absolute cases, as you would expect with increased testing numbers, we're also seeing a relative increase in the percentage of tests that are positive. So when we talk about a percent positivity rate, that number is on the rise, as well as are the new cases. And you can see here in this graph, the 14-day rolling average of new cases is climbing for the Tampa Bay area. Additionally, our hospital beds are being occupied at a higher rate with less available hospital beds. So I think we could probably understand that we have seen a slight uptick here, and exactly how much of an uptick that's going to be remains a little to be seen. Every action probably has a consequence, and we asked people to distance and stay home, and that seemed to have flattened out the curve. So it seems like that worked. So the safer at home Pinellas seemed to have worked. And as we begin to relax things and folks go back to somewhat more of a normal kind of life, it's probably not surprising that we're seeing some uptick in cases. I do also believe that we've had 2 system responders that are new cases in the last week or so. Thankfully, I believe both of those were off duty, not acquired from a patient, but obviously there are still cases and that's still concerning. So I guess the overall point I want to make about this is that as much as we all want to be done, we're not done yet. And I was on a call today with Dr. Osterholm, and he is still saying we are in the second, maybe the beginning of the third inning. And he really is having a hard time predicting more than a couple weeks in the future. And we all need to stay vigilant. A lot of people, particularly those who don't necessarily consider themselves to be high risk type of people, have sort of moved towards everything's back to normal and I'm going to get back to my life. And I think people need to know that the risk is there. And in fact, the majority of those new cases on that graph I just showed were community cases, not long-term care facility cases. So we're talking about young, healthy people in the community who are getting these cases. And we're talking about an increase in prevalence of the infection in communities. So please be cognizant of that. Be cognizant of the fact that, you certainly don't want to bring an infection to work and expose other folks or patients. And please be cognizant of the fact that there is a very clear need to social distance when you can, and when you can't, you should be wearing a mask. Wearing a mask is, the science is evolving on it, but it's pretty clear that that a mask can help. And if everybody, in fact, there's one study that I saw the other day that said if we could get 80% of the population to mask, we would actually be done with COVID in a couple of months. It would be gone because we could break the transmission cycle if everybody, or even 80% of the population masked. So I would encourage you as clinicians, as responsible healthcare providers, to continue to manage your risk and your exposure, whether that's at work or not at work, whether that's at a call or when you're in between calls in your unit or in your station. I think it's important that we realize that this is not done yet, and this is going to be with us for a while. There are only two ways that this is going to end. Way number one is if we get a vaccine, which is, frankly, despite what you might hear, I wouldn't bank on it. Hope is not a strategy. And the other way is if we get to 70, 80% of the population having already had the disease. So something called herd immunity. Now we're currently at about 2 or 3% of the population testing with antibodies. And so we are a heck of a long way from 70 or 80%. So in any case, I realize that COVID fatigue syndrome is setting in, and it's a pain in the butt to wear your PPE, but I want to ask you to please continue to be vigilant, continue to wear the PPE. I know it's tougher as it's getting hotter, but it is the right thing to do. And I'm hearing from medical directors around the country that folks are feeling the same way about their baseline PPE and when to do the full suit. And to a person on the Eagles call today, everybody said, yep, we've got to keep it up. We've got to keep reminding them and encouraging them that this is important to keep doing. So I will echo that. Please stay vigilant. Please continue to use the PPE and please continue to stay safe. So Gary, I'm super sorry about that, but I couldn't resist. Jasmine, any updates from you before we get into David's presentation?
I just wanted to say, if you have questions about masks, our last YouTube last Tuesday was really, really informative. So if you didn't get a chance to watch that and you do have some question about wearing masks off duty and how effective those are, go back and watch that. It was really good. I think that one was a pretty popular one because there was a lot of questions that were answered there. Also, we released on June 1st the PPE June-July CME. And in that CME, we addressed some of the issues that you might encounter with communication with your patients and different ways that you can work through those issues. So that's another tool that you have out there in your toolbox that might help you.
Great. So one of the people here asks, recent cases that have sparked my interest, are we able to review some? So some things that I'm looking at and thinking about are um, uh, who develops immunity and antibodies to this. We think there may be some factors that allow some people to develop immunity via antibodies, and some factors that might make that less likely. We're looking at age and gender and some other pre-existing conditions or other risk factors or demographics to see where that is. There's one case I know of an individual who died of COVID and never tested positive for any antibodies. So it's sort of weird. That's one thing I'm looking at. Another thing I'm looking at is we're beginning to talk about the impacts of COVID-19 beyond just people getting sick with COVID. Or I should say that a different way. The impact of the SARS-CoV-2 virus on the health of our community, in addition to people becoming sick with COVID-19 syndrome. So all those elective cases that got put on hold, they were elective, not optional. Your chemotherapy for your cancer is not optional. Delaying and diagnosing things, we have all of those types of effects, delay of treatment of things. We have mental health impacts for sure. We've seen significant rises in our overdose numbers. The overdose treatment centers are having difficulty staying open and connected to their patients. So all of these things, I'm worried that the actual health impacts of this thing to our community are going to go far, far, far beyond people with pneumonia or respiratory distress syndrome or any of the hypercoagulability stuff or even the pediatric, inflammatory syndrome things. I'm concerned that we're going to just continue to see the ramifications of this for potentially years to come. Related to that, we have been looking at our rates of cardiac arrest, and we've had a significant increase in the number of cardiac arrest calls that we went to in May. And so we're trying to dive into that and see what's going on. Was this people who was putting off their medical treatment and therefore got so sick that they ended up as a cardiac arrest? Were these overdoses? Were these old folks, young folks? So we're beginning to dig into that and try to understand what's going on there as well. Some other cases that are on my radar is the fact that we continue to, in some cases, suffer from maybe some tunnel vision and are missing some diagnoses based potentially upon having to use PPE or being distracted by COVID. But we continue to see delay in recognition of STEMI, delay of recognition of stroke, those types of things based upon having to use PPE or being distracted by other things, namely COVID, that could be going on with the patient. So I guess, Pinellas Medic, the thing I would say the most is you've got to see through all that stuff and still do a good assessment on the patient and still find out what the root cause is going on here. And that can be very, very difficult, but we really do need to continue to try to focus on that as much as possible. All right, so I don't see any other questions in the chat room at the moment, but please go ahead and continue putting your questions in there, and then I will turn it over to David, who's going to walk us through the updates that were covered in the Medical Control Directive this week.
All right, thank you. You can see at this point?
Yes.
Okay. Let's start back at the beginning though. So the inventory for the medication bag, it had been some time since we had done, well, I shouldn't say sometime, about a year since we had done any updates to it. And there's been several changes to the packaging and that we've received for various medications. And it was necessitating us to provide an update to the bag based on that, because we did not see any of those changes that had occurred being able to correct themselves anytime soon. A couple of them we'll run through as we go through here. So where the glucometer currently is, it has remained unchanged. I will say that we are currently working on obtaining a different glucometer because the FDA had a change in which the intent of wave tests utilizing a glucometer has significantly changed for healthcare. So we're currently working on obtaining a different glucometer that is to meet the compliance of the wave tests for healthcare providers. So that will be forthcoming later this year. The actual glucagon, the only change that was done there was an update to the fact that we're getting glucagon now instead of glucogen. That was just a packaging change. Come on. Oh, come on. The Narcan kit remains unchanged. The top exterior pocket remained unchanged, where the IV start kits remained unchanged. The only change that was done here is that currently the self-adherent tape that we get, there's a change in color, and we did that on purpose because the tan color, we had received feedback before previously from hospitals that it was difficult to identify when it was on a patient. And so we had purposely switched to either blue or yellow so that there was contrasting colors. The IV catheters, the only thing that had changed there was an update on the actual images of the catheters. The catheters remain unchanged. It was just a packaging change from BD. This pocket remained unchanged, remained unchanged. This one remained unchanged. Same thing here. Same thing there. The only difference here is we removed the CarpiJet holder. We've not been able to get medications in the CarpiJet format for almost 2 years. So the decision was made to take it out for the time being until Pfizer makes a decision whether they're actually going to start implementing medications in that packaging format again. So there was a significant amount of changes in the lower center interior pocket, and this was due to a number of things. There was actual packaging changes and the fact that we can't get medications that we've previously gotten in their current packaging. So lidocaine in the pre-filled packaging, we've not been able to get for some time. And that's because of the fact that the same company that makes our lidocaine and the atropine is the same company that makes the pre-filled Narcan. So their focus has been mainly from a production standpoint on Narcan. So they use the same equipment, same manufacturing facilities for all of these drugs. They do a different run at the time. And so they're going where the money is at and where the demand is at, which is what the Narcan is. So because of that, there's run a shortage of the pre-filled Narcan, lidocaine. So we've been purchasing it in the vial format, and it comes in the individual kit. The epinephrine, same scenario. That we've had challenges with the pre-filled, and you've seen the kit that has the 1 milligram and the pre-filled syringe of 10 mLs of sodium chloride, and then the needle. That kit's been existing for some time now. In addition, we have switched from the adenosine vials, and there was also a reduction in the quantity. So there used to be 5, and it went down to 3 6s. And it went to a total of 3 pre-fills. The goal has always been to maintain pre-filled medications from a patient safety standpoint. And so right now this is in transition. It's my understanding that there are a lot of folks that still have the vials. And so the decision was made, because we've got both, to just move the vials into the clear packaging that's going to be coming out. That is auto shipping this week. And so you'll have both the containers for either whether it's pre-filled and or the vial to do the same exact same packaging. The calcium chloride that we get previously in the yellow box up at the top, that is also manufactured by the same company that makes the Narcan, and so there's been a shortage of that. We switched to the pre-filled below that is made by Medifill, and it currently is packaged in the hard plastic case that we use for all the other pre-fills that are currently packaged. In the organizers themselves, some changes. The dopamine was removed, and so that in essence freed up basically one container. We were on the hunt for several months for a container to put the 50 ml bottles of sodium bicarb, which I know are not fan favorites. Again, the pre-filled sodium bicarb is manufactured by the two companies that are having a problem. One's having a manufacturing problem. The other one is focusing on Narcan. So it has been on a nonstop shortage for about the last 2 years. And that's why we're continuing to maintain right now the 50 ml bottles of the sodium bicarb. So the goal was to get them into some level of protection because they don't do well sitting in bags that are getting moved around. We've had a couple break, and when they end up breaking, they make an absolute mess in the medication bags. So that's one significant change. So those were put into a solid box, open case box. We have also updated all of the inventory sheets. Those are auto shipping this week with new boxes also. On the back side of those sheets, what used to be the MAC is now the iMac. That has also been updated to reflect the iMac on the back of those sheets. So again, those will be auto shipping this week. Let's see what else changed. The amiodarone moved over to where the adenosine was in the medication kit. And I think that's the only other thing was the STAT2 pumpette, which used to be in with the dopamine, got moved into the box with the 5% dextrose and the magnesium sulfate. Updates here, added the image of the diphenhydramine back in for some time. We weren't able to get the pre-filled packaging of that. It is again available. So once the vial format of that is expended, we'll switch back to the pre-filled diphenhydramine. And I think I updated the picture on the norepinephrine because currently we're getting myelin. No changes there. No changes there. No changes there. That was just the addition of the STAT2 pumpette to the specific box that was moved from the dopamine. And then that's the sodium bicarb kit. And then the sharps containers, which previously were in the bottom of the bag, were moved up to the lid. And that's been for some time as well at this point. Jasmine, I can't see if there's any questions specifically as I was going along.
Nope, none yet.
Okay.
Chief Cepetto just asked, where does the beryllium go?
Right along with the isopro.
Right, yeah. Do you want to know something? I was just giving him a hard time showing his age. But in orientation yesterday, not a single, I think maybe it was one person, but I think not a single person in orientation yesterday knew what a mast pant was. Can you imagine a whole room of new medics and EMTs and nobody's even heard of mast pants?
So I will say in summary that we've had an ongoing challenge maintaining some consistency in the packaging that we get medications in. So it's been a challenge to also deploy and maintain that in some consolidated fashion within the confines of the bag without expanding the actual med bag itself. There's a lot of hours that go into a puzzle. I understand it's tight and it's difficult, and we have attempted to keep in mind what comes out of the bag first. So on the cardiac arrest, you're not pulling the sodium bicarb out first. So the intent is that the epinephrine is readily available. Same thing with the medication box and the syringe box. So the stuff that is going to be used, very similar to the way the rest of the bags are set up, that the deeper you get into the bag, the more intense the call is. So that's when the other stuff starts to come out, and we've attempted to keep that in mind with all of the bags as we've gone along. We're certainly open to any type of feedback or questions. I'm happy to. You can either go through your coordinator if that is so directed, or you can email me direct, and I'm happy to answer any specific questions as well.
David, I just had a question or suggestion for an unfiltered 18 gauge needle in the bicarb kit to help draw it up easier.
Yep. And so let me explain a little bit about that. The reason we have not done unfiltered is because we used to have two different ones in the system. And so the filter is important for utilizing with solumedrol or calcium. Whereas the straight 18 gauge, we had folks that were trying to give IM injections with 18 gauge, which is extremely painful. And so in an effort to narrow that down to kind of drive human behavior, the decision was done to put the filter in, because that way, if the filter is used, and I understand, especially with amiodarone, it also can cause some foaming when it draws up. I wish they would come out with a pre-filled of amiodarone. I'm not sure what the delay is with that. It was out for a little while by a company called Sagent, and then it was pulled. So I don't know what the delay is with that, but as soon as it comes back into some form of pre-filled, we will certainly seek that out and put it into the bags. But that's the reason why the filtered needles are in the system as opposed to having both. That answered the question, I hope.
Yeah, I think so. So when they become in pre-filled, we will have them.
Yes.
We'll make it work for now.
Yeah, by the way, it's not just us. The same thing is happening in the hospital right now with the bicarb, and we have to draw it up by hand when we're doing it. It is what it is. No way around it.
There has been some import of bicarb, but it's 10 ml syringes of it. And so again, for us to put that many in a bag, it's not gonna work. We're gonna carry a bag around just of sodium bicarb.
Yep. Okay, did you have anything else, David?
That's it. That's all I got for today.
Okay, so in the comment section, please, any questions for David? And while you're doing that, I will give a quick update on testing. And then we'll take any other questions, and we'll try and keep this one a nice and pretty short one today. So we did have our IRB approved, and we went ahead and got our testing samples collected from our 30 volunteers. So thank you to all of you who participated in that. The lab side of that is ongoing right now, and we expect to have our whole 30 first responder and 30 known positive from the hospital data sample ready to go in the next day or two. We will do a little bit of analysis on that and then make a decision as to how we think the test is performing and how we think we ought to proceed going forward with it. But I would say that based on the preliminary numbers I've seen, I think we will probably be confident in saying we can go ahead and deploy that test to the whole system. So anticipate hopefully in the next couple of weeks that we would get the entire system screened for antibodies at least once, and then we'll figure out where to go from there. I think that'd be helpful just in terms of information that folks might want to know. And obviously if you test IgM positive, we would go ahead and do a nasal swab on you and make sure that you're not actively infected. And then if you test IgG positive, depending on the performance of the test, we may or may not say we need to go ahead and do a confirmatory test on that as well. So we'll see how the numbers shape up, but we were able to get that done on Friday, and special thanks to the folks who volunteered and came down to do that and let us draw their blood, etc. Let's see, any other questions from the group? Chief Bessler says the bags are working well. He also says he's volunteering a medic by the name of Shane Hudak for invasive experimental procedures. So I don't see much else in the comments, and I'll give it another minute to take any questions and just I'm still waiting for any questions. I got nothing. Okay. So that picture is pretty good. I think we have to have a competition about who's got the funniest picture from when they were in high school. So, all right. Again, I don't see any more in the comments. I think unless anybody wants to chime in with something else, we will call it an early one this afternoon. And I can't emphasize enough that we are not done with this thing. As much as we all want to be done with this thing, we are not done with it yet. Am I still encouraging daily wellness checks? Absolutely. Absolutely. We've had any number, double digits, maybe probably a total of something like 20 folks who were out on isolation because of an exposure over the last week or two, Chief. And so, yes, absolutely. Keeping the station safe, keeping your ambulance cab safe by doing screening to make sure that folks who are potentially sick aren't coming to work is absolutely a strategy that we need to keep doing. Chief Cepetto says the state is going up, but so are the number of tests. Is the percentage still the same? No, the percent positivity is also rising. So the percent positivity is rising. So you cannot say that the overall number of cases is due to the fact that we're just testing more people, because the percentage of the tests that we're doing that are coming back positive is also rising. So hopefully that answers your question, Chief Cepetto. I would, for those of you who haven't watched it, I would strongly suggest you watch last week's YouTube with Dr. Shepke talking about masks and thinking about infection control at home, off duty, in the community, in the fire station, the front of the ambulance, in the office, all of those places, and what things we can do to minimize the risk there. Because the risk is real. This increase in cases that we're seeing right now is in the community. It is not in long-term care facilities. It is young and healthy people in the community out there getting exposed during social events or normal community activities. So please understand that as much as we all want it to be over, it's not over yet. In addition to the talk from Dr. Shepke, last week, there's also, if you go to that CIDRAP website, the CIDRAP website, there's a podcast from Dr. Osterholm on the use of masks. I was on a call with him today, and he is working on a scientific position statement with a group of experts around the world on mask use to hopefully help with the guidance and making the case to people that masks are very, very important. But I really, if you want to listen to either one of those, I strongly suggest it. And I strongly suggest that you consider wearing a mask anytime you are not able to effectively social distance. So anytime you're indoors with a group of people where there's any number of people in an enclosed space, you should probably be wearing a mask. As I said before, there was one study that even said that if we could get 80% of the population to wear a mask all the time, we would be done with COVID in a couple of months. So whatever you can do to help us minimize the spread now that things are opening back up a little bit is going to be to your advantage and to the advantage of your patients and to the advantage of the entire community. I see one other question in here about COVID positive pediatric patients. So I don't know the answer to that, Shane, because we have a separate pediatric ER there. And so I can't tell you quite the same volume. I know we are testing more pediatric patients than we were before, just like we're testing more adult patients. But I don't know the breakdown of whether the percent positivity in pediatrics is going up. But in general, the age distribution of cases is coming down because it was skewed towards the long-term care facilities before. Any particular type of mask or just a mask? Obviously, a tested, properly fitting N95 respirator would give you the best protection. And there's growing evidence on what type of protection and how much of protection, various things from surgical masks to procedure masks to cloth masks or homemade masks might offer. There's really in the public, I would say anything is better than nothing. And while we probably need to preserve our N95 masks for actual use during patient care or when we're in high risk gathering scenarios, some type of mask, whether it's a procedural mask, a surgical mask, or even a cloth mask, is useful in public. Some particular types of cloth fabric are better than others. For example, a high thread count cotton or a quilting cotton material is very effective. If you combine that with a layer of silk or spandex-like material that has an electrostatic charge to it, you get two different types of filtering. And there was even one piece of data last week that showed if you wrapped a nice silk scarf around your face 4 times, you are almost as good as an N95 mask. So really, whatever you can get, Rick, I think is worthwhile anytime you're inside or in an enclosed space, and certainly anytime when physical distancing isn't an option would be certainly advisable.
And in our stream last week, he actually went over multiple masks and how effective they are. So if you go back and you look at that or watch it, it actually breaks down all the different types of masks and how effective they are.
Yeah, perfect. And then Chief Bessler asks, are all patients entering an ER in Pinellas getting COVID-19 tested? I don't know the answer to that, Chief. I know in my ER, if you get admitted to the hospital, you get tested. If there's a reason to test you, you get tested, even if you're not being admitted. And if you're being discharged to a long-term care facility or any other kind of congregate facility, whether it's a psychiatric facility, jail, drug abuse treatment facility, whatever else it might be, you're going to get one before you go. So we're doing that at my hospital. I don't know about all the hospitals in Pinellas. I suspect that they're not testing every ER patients. All right. Any other questions? Other comments? Okay. Final comments from Jasmine or David?
Thanks for tuning. I'll say thanks for tuning in and continuing to watch these. I know a lot of people watch them after the fact, and you're always welcome to go back and watch, other streams. 2 weeks ago, we had Peter Antevi on here talking about pediatrics and COVID. That's a good one to watch too. And don't forget, you have that PPE CME that helps with the effective communication. We're always looking for suggestions. So for all of us, if it's protocol related to the bags or related to anything that's going on with CME or anything that makes it easier for you out there, whether it's something that is working when you're drawing up different medications on a code, if we're talking about the different packaging for the medication and you have something that works for you, if you have something that works for you in relation to communication, just let us know. You know how to get a hold of us. All of our information should be on Target Solutions as well.
All right. Sounds good. Okay. Chief Bessler says nylon stockings over your head in a bank are not protection. Interesting quote from, I believe it was Dr. Osterholm on the call today, who said, if you're just covering your mouth with a mask, you're a bank robber, not protected. So make sure that mask is over the nose and the mouth. Otherwise, you just look like a criminal, right? I thought it was a funny reference he made. I don't think I delivered it nearly as well as he did. So anything else? All right. That's it from my standpoint, Jasmine.
All right. We will see you guys next week. Let us know if there's anybody else you want to see on here.
Okay. Stay safe, everybody.